Hello, everyone. Let's give everyone about 2 minutes to join, and then we'll get started. Thank you for joining us. These are the longest 2 minutes of my life. Hello, everyone. Hi. Thank you so much for joining us today. We are so pleased we're able to get together virtually during this unprecedented time. We hope you're just as excited as we are. We have a lot to cover over the next hour, so let's begin. Next slide, please. Here's an overview of how our hour together will go. First, our panelists are going to introduce themselves, and then we will tell you about our very special women's cancer program at the Blavatnik Family Chelsea Medical Center at Mount Sinai. Then we'll address our clinical trials program, talk about the safety precautions we're taking due to COVID, and following that, we'll just give an example of a patient that will be referred to our center. And finally, we'll answer as many of your questions as time permits during our live Q&A session. Next slide, please. I am delighted that my colleagues are here with us today. Joining me are Dr. Samantha Cohn, Dr. Valentin Kolev, and Dr. Kristen Zeligs. I'll first introduce myself. My name is Stephanie Blank, and I am the Director of Gynecologic Oncology for the Mount Sinai Health System. I'm a professor in the Department of Obstetrics, Gynecology, and Reproductive Science at the Icahn School of Medicine at Mount Sinai, and the Director of Women's Health at the Blavatnik Family Chelsea Medical Center at Mount Sinai. Thank you. I'm excited to be here. And next, we have Dr. Samantha Cohen.
Hi, I'm Samantha Cohen, and thank you for joining us. As Dr. Blank mentioned, I work at the Chelsea Medical Center. I also work in Brooklyn. I'm the Director of Gynecologic Oncology at Mount Sinai, Brooklyn. And I've been at Mount Sinai for most of my career, which is about 18 years now. So it's great to have you. Thank you for joining us.
Thank you. Dr. Kolev.
Hello, everybody. My name is Valentin Kolev. I'm an assistant professor of gynecologic oncology at the Department of Obstetrics and Gynecology at Icahn School of Medicine. I see patients also at the Chelsea Center, Blavatnik Family Center. And I also trained at Sinai and have been at Sinai for most of my career.
Fantastic. And now Dr. Zeligs.
Hello, I'm Kristen Zeligs, and similarly, I am an assistant professor through Mount Sinai and work at the Blavatnik Family Cancer Center, the clinic there. I also work through Mount Sinai Hospital and Mount Sinai West, And thank you everyone for joining us today.
Thank you. Now I'm going to hand the program over to my colleague, Dr. Cohen, to tell you about the Blavatnik Family Chelsea Medical Center at Mount Sinai and our very special women's cancer program. We are located on West 15th Street in Manhattan between 8th and 9th Avenues, right across from Chelsea Market. Dr. Cohen.
Okay, so the Blavatnik Family Chelsea Medical Center is part of the Mount Sinai Health System. And it was specifically designed with the goal of creating a space for women that is welcoming, comfortable, and unique. We established our women's cancer program here within our Chelsea facility with a distinct purpose: to provide the most advanced, comprehensive care by our team of women's health specialists in a soothing environment. Our program focuses on gynecologic cancers, as well as non-cancer gynecologic conditions, as well as breast cancer and non-cancer breast conditions. What's special about the Blavatnik Center? As you can see from the pictures, we designed the center with your patients in mind. It is small, intimate, and comfortable. It has the latest equipment, including 3D mammography. It has fully established and equipped operating rooms so that our outpatient surgical procedures can be done right here. It has a modern infusion suite for patients who need chemotherapy and other infusion treatments. In addition, we have an amazing wellness and support staff and programs that focus on our patient as a whole person. So basically, patients can get everything they need right here. And I will now turn over to Dr. Kolev to discuss what conditions we treat as part of our women's cancer program and to give an overview of what is a gynecologic oncologist.
Can we have the next slide, please? As you can see, we specialized in diagnosis and treatment of female reproductive cancers. We also, that's the wrong slide. There you go. So we provide services and we specialize in treatment of gynecological cancers, which are cancers of the female reproductive tract. And that you can see from the list includes ovarian, uterine, cervical cancer, fallopian tube cancers, also vaginal and vulvar cancers. We also treat non-oncological conditions that, benign diseases of the gynecological system, including pre-cancerous conditions, cervical dysplasia, pelvic masses, ovarian cysts, fibroids. We also, at the center, provide the full spectrum of breast services for breast cancer and non-cancerous breast conditions, as infections, pain, enlarged lymph nodes, breast thickening and lumps, fibrocystic disease. The way that we provide care, we use a multidisciplinary approach for treatment of our patients, where we use the full spectrum of specialties on site. We do have hematologic oncology, radiation oncology. We have our own lab, and also we provide diagnostic services in terms of imaging. We do treat our patients on site, and this way that makes it very convenient for the patients because they provide and they received all of their care at one place. Also, we provide genetic counseling services and nutrition services as part of the whole multidisciplinary approach. We all are specifically trained in gynecologic oncologist, and if you're wondering what that may be, we initially completed a residency in obstetric and gynecology, and consequently to that, we undergo a fellowship in gynecologic oncology. That is an additional 3 years of training that includes the full spectrum of oncology treatment training, including surgery, chemotherapy, and that's what with the goal to provide a specific care for female gynecological cancers. the gynecologic oncologist, you can look at as a captain of the team of that multidisciplinary approach. We coordinate the care that is its all entirety, including the surgical planning, the actual surgery, the chemotherapy, the radiation therapy. All the patients are presented in multidisciplinary tumor boards where the plan is made, and every patient gets individualized treatment plan based on the specific condition, including, operative findings, stagings, genetics, predisposition.
Thank you. So now we'll speak about the clinical trials program here at the Blavatnik Family Chelsea Medical Center. And I have to say, we are really proud of our clinical trials program. We have multiple trials across all of our main disease sites, and just for the ovarian, uterine, and cervical cancers. And our trials really cover the gamut. We have a massively expanded program. Our trials include treatment for our main cancers, as well as prevention trials where we look at molecular findings in the tissue or circulating tumor DNA, some about decision-making and quality life and risk-reducing surgeries. Through trials, we have access to novel therapeutics, sort of the latest and the greatest in cancer treatment. And this includes things like immunotherapy and targeted agents. And these are just different than chemotherapy. This is a completely different way. We have ways to treat cancer that are completely different than ever before. And the thing that's really important about trials and really exciting about trials is it really moves the care of our patients forward. Trials are how we advance science, and we are really proud to be able to offer our patients enrollment in clinical trials. So that's about trials. Now I'm going to turn it over to Dr. Zeligs, who is going to talk about the safety precautions we're taking due to the COVID-19 pandemic. Dr. Zeligs?
Yep, great, thank you. So we have many safety precautions that have been put into place for our patients since the development of the COVID-19 pandemic. So prior to a patient's appointment, they're pre-screened over the phone for symptoms of the coronavirus, as well as any recent travel. And then all patients, visitors, and staff are also screened upon entering the building. If a patient screens positive at the screening desk, they're brought to an isolation room and are further evaluated by the clinical team at that time. We have spaced appointments, so we have fewer people in the building at any time. Our waiting rooms are purposefully not overcrowded. And as employees of Mount Sinai, each day we get our temperature checked and attest to having no symptoms. An additional precaution is limited visitors in the building. Currently, visitors are only approved for patients for whom a support person has been determined to be essential to the care of the patient, patients who have an end-of-life discussion with their clinical providers, and patients coming in for an initial consultation to the office practice. In addition to screening patients prior to their office visits, all patients receiving cytotoxic chemotherapy agents are required to have a COVID test 2 days prior to their treatment visit. Additionally, patients are required to have COVID tests at a minimum of 5 days prior to any surgical procedure.
Great, thank you. Thank you so much. Yeah, we do a lot to make sure that our patients are safe. We know that our patients are very concerned about their safety, as are their families. Now I thought I'd provide an example of a patient cared for here at our center to sort of describe a little bit of what we offer. So this is a woman who was in her early 50s, and she went to her gynecologist with some abnormal bleeding. The gynecologist did an ultrasound, which shows a polyp and a hydrosalpinx, basically a mass in the fallopian tube. And that gynecologist wanted to take her for a laparoscopy and a hysteroscopy to address both of these issues. This was in February of 2020. On placement of the laparoscope, the gynecologist noted that there was a lot of scar tissue, that the tube really couldn't be mobilized at all. So aborted that portion of the procedure, did the hysteroscopy, and that was negative. Then 4 months later, the patient continues to have abnormal bleeding. Of course, COVID hit during this time, but that's not part of the story. That's just happened to have happened. The patient then had a second hysteroscopy, and at this hysteroscopy, she had a fragment of serous cancer and a polyp again. So she was referred to our center. And when she came here, she really had this discharge that's really typical of tubal cancer, like hydrops tubae profluens. It's like this watery, bloody discharge. So pretty high concern this was actually a tubal cancer. And in fact, we checked a CA-125 and it was like 1,000. We did a CT scan and it showed a mass on the adnexa as well as some disease in the omentum. So the patient was quickly taken to the operating room and had a stage 3C fallopian tube cancer and recovered well from surgery. Now, importantly, this patient had absolutely no family history, but we did do genetic testing on her as we do for all of our patients with this kind of cancer, and she was found to have a BRCA1 mutation. She has 4 children, and all of these children are now being tested, and they're actually being sent to a new program we have, the Center for Cancer Prevention and Wellness. This is at Union Square. And they're all getting tested, and they'll undergo appropriate screening or risk-reducing procedures. And this patient is also hooked in with a breast surgeon who will be following her once she's done with her treatment. In terms of her treatment, she's now 5/6 of the way through her chemotherapy. And she's using these cold caps that we have to help prevent hair loss. And after this treatment, she'll be able to go on a PARP inhibitor, which is a targeted therapy, something that really works well in women with BRCA mutations. And this should really extend her life. At least it seems 4 years longer than if she weren't on that medication. So it's I thought this was a good story, a good patient to talk about because it gives a good idea of the type of patient we should be seeing. If you have something going on that just doesn't make sense, we're happy to give you our 2 cents. We really work to expedite care. We'll get your patients in as quickly as possible and take care of them as quickly as possible. And we provide everything, as Dr. Cohen said, at our center. This story also just really hammers home the importance of genetic testing as well as the downstream effects of genetic testing. So I hope that was okay. Thank you, panelists. We are all New Yorkers now, and we all spoke very quickly. So we hope that we were able to answer many of your questions. We'll now switch gears and allow all of you to send in some questions. If you have any questions for us, you can send them, go to slido.com and use the code HEALTH to submit that question to our event. I'll read through as many as I can as time permits, and I'll ask our panelists to answer them. While we're waiting for questions to come in, I will just start with a few questions that we often get asked by our patients. And just so you know, our panelists do not know they're going to be getting asked these questions. Dr. Cohen, do I really have to get my son or daughter vaccinated for HPV?
So yes, you do. And we have really, level 1 evidence to support HPV vaccination that covers many, many years of collecting results on all the children that have been vaccinated in very successful vaccination programs, mostly not in the United States, but in other countries. And we're hopefully going to follow suit here. But, we know from the studies that have been published, for example, there was one meta-analysis that was published in the Lancet that was covered 65 studies that represented 60 million people who had been vaccinated. And it was at least 8 years of follow-up. And we know from this study and others that the incidence of high-grade cervical dysplasia in these patients was decreased by over half. So we know that the HPV vaccine works. We know that it reduces the cancer-causing HPV subtypes. We know that over time, we will see a decrease in the number 1 cancer that it causes, which is cervical cancer, but also, the other cancers that are found in men, like laryngeal cancer. So it's also a very well-studied vaccine, as I mentioned, and the in terms of the safety profile has been well studied. So it's very important that all children get vaccinated.
Thank you for that amazing answer. Thank you. And that actually spurred some questions that came in. And Dr. Kolev, I'm going to address this to you. It's kind of more than one question. I apologize for that. So first of all, what do you think about the HPV vaccine for women in their 30s and 40s? And I'm going to ask all of these, and I'll remind you, sorry. Then what about for people that already have dysplasia? And if somebody has had the vaccine, gets dysplasia, do you revaccinate? So 30s and 40s, already have dysplasia and revaccination.
Okay, so one at a time. So in terms of the 30s and the 40s, initially when the vaccine was released, the study, the way that it was performed, it was in a population that was up to the age of 27. And that was the initial FDA approval that women should be vaccinated up to the age of 27. However, last year, I believe it was last year, the beginning of last year, that was expanded actually to the age of 42. So technically, we do recommend vaccinations to be performed in the 30s and 40s. I think the confusion in the past has been, different in terms of recommendation and reimbursement for the vaccine. And initially, the insurance companies were reimbursing the vaccine up to the age of 27, but that was not like contraindication that the vaccine cannot be administered after that age. Then, in terms of giving the vaccine to the patients that have already developed a dysplasia, the data actually shows that, once the virus has established and there's already a dysplasia, giving the vaccine doesn't have a curative effect. It's not going to remove it. However, there's data to show that there's some protective effect of the vaccine in terms of the progression of the disease. And again, this is not the contraindications. Having the dysplasia doesn't mean that a woman cannot get the vaccine. And in the last question about revaccination, once we believe that the immunity that is developed from the vaccine, one is established, we don't have any data to show that actually we have to revaccinate if the initial vaccination was administered properly with 3 consecutive vaccines. So at this time, we would not recommend revaccinations to the patients that have already received the vaccine.
Thank you, Dr. Kolev, and I'm sorry for the compound question. Never a good interviewer technique. So here's another question that came in, and I'll address this to Dr. Zeligs, and maybe you can expand upon it. It's a yes/no question, but you'll expand upon it. It says, can I send a woman to the Center for Cancer Prevention if she has a close relative with a family history of ovarian cancer but negative genetic testing? So would this type of person be appropriate to be seen by us?
So I think yes, for multiple reasons. First, we always welcome if there's a patient that you're caring for who wants additional information that you feel like you're not maybe able to provide your level of expertise. We're always here to assist in any way we can. And sometimes I think even just to have a reassuring visit to discuss with the patient their specific risks and things that they can be doing even just to minimize risks, and taking a good family history to better understand that, to make sure that their genetic testing isn't necessarily outdated, and that, understand what testing has been performed for that patient, and just to help with an exam if that's going to provide you or the patient more reassurance. Again, we're happy to help however we can.
Excellent. And I'm going to ask this question of myself, and that is, do you see men with BRCA mutations? So actually, I would say I personally don't see men. I've definitely ordered BRCA testing on men. But I would say a man with a BRCA mutation should probably go to the Center for Cancer Prevention and Wellness. Again, the program that is at Union Square. It's a new program as well that we work very closely with. Dr. Cohen, another question for you, sort of along the same lines. So, I find that this is a question, it's not me. Patients don't necessarily want to know if they have a genetic predisposition to cancer because they feel like there's nothing they can do about it. So how do you address a patient that feels this way?
So I always start by talking to the patient about, and generally speaking in medicine, we only do tests that have an outcome that is positive in terms of improving their quality of life, improving their health outcomes. So we don't offer tests and we don't pursue things, generally speaking, where we can't do something positive to help them live a long and healthy life. And that, when I usually speak about it in that way, I think patients generally sort of come around. And more specifically, especially in our BRCA patients, I speak to them very in specific details about, by knowing the results of this test, how the different ways that we can help them prevent ovarian cancer by doing the risk-reducing surgery at the age-appropriate time. And also, I talk to them about breast cancer screening that's enhanced, and certainly they fall into a different algorithm of screening and care if they test positive for a BRCA mutation. And usually, after we've had that discussion, I think for most patients, it goes a long way, and they do feel more comfortable with undergoing testing.
Excellent. Here's a question for Dr. Kolev. If I'm referring a patient to be seen by your team, what records or recent testing do they need?
Well, I mean, ideally we want all of them, all the recent testing and imaging that they have. And it really depends the reason for the referral and why the patient has been referred to our center. But, we try to obtain all the records prior to the visit, and our team on the back end works on obtaining all relative records, regardless of where they were done, in an outside institution, in a private office. So by the time the patient comes to visit us, we actually have reviewed the records and the reason for the visit, and we are prepared for the patient in a way. And even sometimes if we feel based on the referral that something is missing, we'll try to obtain some of imaging or lab results before we even see the patient.
Excellent. Dr. Zeligs, what should I do if I'm not sure whether someone should be referred to a gynecologic oncologist?
So I think you can always reach out to us and inquire before sending them. There's multiple ways to get in touch with any one of us, and we're always happy to help figure out if your patient kind of meets criteria to need to be seen by us, or if we can help in any way. But I think most of the time when you are wondering if a patient should be referred to a subspecialist, that sometimes can be the telltale sign that there's something there that's making you concerned that you may want our assistance. And again, we're always here to help in whatever way we can.
Thank you. Dr. Cohen, my patients get scared when they hear they need to see a cancer doctor. Do you have any advice?
So I think that's one of the unique parts about our center, or characteristics, as I mentioned in the beginning. It's a very inviting place. There are many different types of patients that come there for other problems besides cancer, other diagnoses besides cancer. And I think if you can talk to your patients about, that part of it, that we just see complicated gynecologic problems, not just cancers. And in addition to that, it's a very warm and inviting place. I think that helps patients sort of have the courage to come visit us.
Thank you. Dr. Kolev, this question is just for you. What is the difference between laparoscopic and robotic surgery?
There's no difference. It's the same surgery. It's just the tools that are utilized. They're both minimally invasive surgeries. With the robot, there's more freedom of movement with articulating instruments, and a 3D camera is utilized for a better visualization. With the traditional laparoscopy, it's traditional way of using and manually controlling the camera and using the laparoscopic instruments, but the procedure by itself is exactly the same procedure using different tools. We do utilize all of them. We do robotic surgery, laparoscopic surgery, and they have their advantages and disadvantages. I personally think that robotic surgery is easier to perform on patients with a higher BMI. It's just the way that the system works. It makes it more ergonomically effective. For some complex procedure, the argument is that the robot makes it easier. But on the other hand, the laparoscopy and the robot is exactly the same procedure, the way that it's performed, the same steps are utilized.
Great.
From the patient's experience, I don't think there's a difference for the patient. And then sometimes it is provider preference in certain cases, but we do use both modalities.
Great. Dr. Zeligs, can you talk, there's some questions about oncofertility. Can you talk a little bit about what type of services we have?
Yeah, so we have practitioners that come to Chelsea as well who work particularly with oncofertility. So for patient populations that are concerned about future fertility and have a diagnosis or maybe even a presumed or possible diagnosis, that we're able to utilize these services to better counsel our patients prior to undergoing a procedure or any type of cancer treatment which may affect their fertility. We always have consultation with certain specialists who can really guide us in regards to options available for each individualized patient with regards to oncofertility.
Perfect. Thank you. We also have a question here about the Center for Cancer Prevention and Wellness, which I mentioned before. And I'm sorry, we didn't prepare a slide on this, so I'll speak slowly because I guess I'll speak slowly here. There is a general number, which is 1-844-MD-CANCER. And again, that's the Center for Cancer Prevention and Wellness. But there's also an email, and that email is unionsquareccpw@mountsinai.org. I'll say that again in case you're writing it down. It's unionsquareccpw@mountsinai.org. All right, where am I? Dr. Cohen, how early do you think at what age do you think, I'm not going to say children, but younger people, what age do you think is the right age to genetically test, say, a daughter of a woman with a BRCA mutation?
So I would recommend, could either, if for some reason there's a close family member with a very early cancer, let's say, for example, in their early 30s, then I would recommend testing, somebody in their early 20s. In other words, 10 years younger than the cancer onset in the close family, in the close relative. But that being said, the SGO and ACOG recommend that in terms of the breast cancer screening for these patients who have, for example, BRCA mutations, we do want to begin that screening between the age of 25 to 29, and specifically alternating breast MRI with mammography. So if you don't have a family member that is a close relative that had cancer, that would cause you to test them earlier than age 25, I would say at least consider testing them by age 25 so that between age 25 and 29, they can begin the breast cancer part of it.
Great. Thank you for that. And again, sort of along those lines, Dr. Kolev, what do you see people that have variants of uncertain significance?
Yes, we do. And so the variants of uncertain significance, so the issue with that is, there are some rearrangements in the gene, for example, for BRCA gene. And this basically means that these rearrangements have not been associated with cancer development or increased risk for cancer. We do, when we started mapping out the DNA and started mapping out the BRCA genes, they're actually quite large. And then certain rearrangements in the genes were found to be oncogenic in terms of developing cancer. And then certain rearrangements of the genes have not been associated with increased risk for cancer. And that's where the unknown significance comes, because it is rearrangement of the sequence, but we don't know if that actually has any clinical significance. As of right now, we do not treat these patients as having a mutation that is oncogenic, and we do not treat them differently than the general population.
Great, thank you. Dr. Zelig, this will be our last question unless one comes in the next little bit of time. There's a question here, Dr. Zelig, about other members of the healthcare team. Who else do patients see when they come to our center aside from the physicians?
Yeah, so that's a great question. So we have a multidisciplinary team that helps us care for our patients. Within each of our individual clinics, I think most of us utilize a nurse practitioner as well as a nurse to help see our patients, to obtain histories. Some of us also sometimes have a resident or fellow in with us or medical student for clinic as well. In addition to that, patients who may need additional resources, we have a social worker and a nutritionist on site who often are able to see our patients same day if any needs arise that their services could be utilized. And those are really, I think, the primary sources for us of who sees our patients in their typical clinic visit.
Thank you. And thank you, panelists, for fielding so many questions. Now, I think we are going to close up the program and let everyone get on to their evening. It's been an absolute pleasure sharing this information about our women's cancer program with you and helping to provide further awareness around gynecologic cancer. Oh, I didn't say it is Gynecologic Cancer Awareness Month, so just be aware of that. Again, thank you for your time, and we really enjoyed this afternoon.
Thank you.
Thank you.
Thank you.